Take you through the guidelines that we have, and I will show you how it includes not just 2D, but whenever required, we do a 3D or 3D with or without color. We can do it even in the early trimester, and wherever required, we can use basic or advanced MRI. And the question is, do we still require it? And we must understand that when we look at what is happening in our part of the world, and we look at the Indian subcontinent, as it is called, which is Pakistan, India, Nepal, Bangladesh, and Bhutan, then we do realize that we still have the highest number of neural tube defects, which is why that in spite of all the great work that has been done to overcome anomalies, the cardiac anomalies are still not the most common because we have this. And so I will take you through a little bit more of the background. When we do a neurosonogram, technical factors, a little bit about basic examination, although my colleague Dr. Petia has already taken you through that, then the hardcore fetal neurosonogram, and one or two take-home messages. We must realize that we no longer use the old guidelines, which were from 2007, the top left ones, and we have a new paper that came in from an usg4 group in 2020, and these are in two parts, part 1 and part 2, and they tell you how to do a neurosonogram. Copies of this, as usual, are free on the usg4 website. There is also another very good guideline which is almost similar, but it is highlighted and makes easier reading, and I like to use it, and it's in the Perinatal Journal of 2021, again as an excellent free download, and it's by several famous names, as you can see here, including Ritsuko Pu from Japan and Ravi Shawi, and again it tells you the same thing but in a more easily digested manner. So I truly love that, because what they tell you to do is that to understand the brain, we have to go beyond the basic planes, and the basic planes, as you've learned already today, are the transthalamic plane, which is our BPD plane, which is this one where we make our measurements, the transventricular plane, which is above the transthalamic plane and perpendicular and parallel to it, which is this one, and this one, which is the transcerebellar plane, where you have a posterior tilt and you get to see the cerebellum, the cisterna magna, and the nuchal fold. What is central to all these three planes, and you must understand that, is that each one of them will actually show you the cavum septum pellucidum. So none of these planes should be identified unless you use that cavum septum pellucidum at its center. What we've ended up doing beyond that is this, that in the neurosonogram, we use a series of coronal planes, which is these ones here, a mid-sagittal plane, and two oblique parasagittal planes that will become part of what we call an extended protocol or the neurosonogram, and this enhances detection rates. Is this possible only in the second trimester? And the answer is no. We have a separate set of guidelines which we're not discussing today, and those are the first trimester neurosonogram, in which instead of just the two planes that you learned this morning, which is the one through the aqueduct of Sylvius and the one, this one, which is through the choroid plexi and the lateral ventricles, we also make sure that we look at the brain in the mid-sagittal NT plane, that we have a posterior approach to see the posterior cranial fossa, and we have cranial planes from front to back. We also use the axial planes to measure the lateral ventricles, and we use color to identify vascularity in the posterior cranial fossa, where we find that the junction of the superior sagittal sinus and the straight sinus can tell us about masses in the posterior cranial fossa and also about neural tube defects. But that is not what we will discuss today. What we will discuss today is the standard one that we usually do at about 20 or 22 weeks, and the reason for that is that the corpus callosum may not be absolutely in place until 22 weeks. Of course, you could do it earlier when it is indicated, and of course you also do it later in case you find an abnormality, in which case you will do it in the late second trimester whenever required, or in the third trimester. But do remember that morphology changes with gestational age. So if you were to look just at my most favorite structure, which is the parieto-occipital sulcus, you do understand that it can be very shallow to start with and very pinched. And where this pinching starts is where we do the measurements, and therefore all of that is quite different. This business of the brain being different has been recognized for quite a few years now. And the morphology is quite different at 12 weeks, as you see here. And these are images from the usg4 document. At 21 weeks, these are the 3 standard planes. But by 32 weeks, the ventricles are much narrower. You do understand that the aqueductus sylvius is no longer seen, and that the cavum septum is no longer so prominent. Therefore, you must realize that gestational age is important. The other thing we do realize is that as the head grows, the brain gets lost behind the bone which gets ossified. And therefore it might be very tricky to actually do a neurosonogram when we're going to be doing a study beyond 26 to 28 weeks of gestation. The neurosonogram encourages us to go beyond 2D, and the most useful indication really is to be able to visualize the corpus callosum. Sometimes you're lucky. Even transabdominally, you might manage to see one. Most of the time, you end up doing a transvaginal scan, but 3D, because it has enhanced contrast differentiation without the use of radiological contrast, will show you beautifully the entire corpus callosum and the vermis of the cerebellum by a single sweep by a transabdominal approach. If you use a transvaginal approach, then it becomes even easier. 3D is also useful because we end up using, again, that contrastiness to see the sulci much better, to see the ventricular outline much better, and even in the coronal plane, you can beautifully outline the corpus callosum at a point where you can see the cavum septum pellucidum so clearly. And here, look at this beautiful demonstration of the corpus callosum, and you can see the vermis of the cerebellum, and you can see the brain semsto beautifully. When you do a 3D sweep, you can also cut across by either wider slices in any plane or narrower slices. So the coronal imaging becomes very simple. So straight away you get what we call a transfrontal plane. You will then get a transcaudate plane, a transthalamic plane, and a transcerebellar plane. So 3D facilitates this. 3D helps you in orientation, and you can play with it. The other technology we play a lot with routinely is to use color. The most useful technique, of course, is when we try and assess the corpus callosum by demonstrating the course of the pericallosal artery. And then you see it just like this, and you can be sure that yes, there is no sunburst appearance and the corpus callosum must be there. We also use it for any cystic space that we see in the brain, because any cystic space may not necessarily be a water-filled cyst. It could very well be a vascular structure, such as a vein of Galen aneurysm. Fetal neurosonography also encourages the use of MRI as a problem-solving modality. And the 2 areas where it is particularly useful is if you have a huge amount of fluid in the brain, or for looking at schizencephaly. We've had something called the Meridian trial, which says that, look, MRI gives you much, much more. But the Meridian trial was done in the northern part of England, and in the northern part of England, they realized that they were picking up only 40% of CNS anomalies, and the remaining 50 to 60 were picked up by MRI. But there's only one conclusion you can come with that if somebody's picking up 40%, then in the northern part of England, they need to be trained to do basic neurosonography. And there is no other conclusion, because you can't be so ridiculous as picking up only 40%. You and me do these every day, and therefore it's not MRI to be done for everybody. MRI only has a specific location, such as this case here. So here, for instance, we find that there's an obvious absence of the midline. I don't see a cavum septum pellucidum. I see dilated ventricles. And here, inside the eye, I see an echogenic area, which could either be a cataract or a coloboma. I do a 3D and I discover a depressed bridge of the nose, and then I say, okay, Here it is. I find most of the corpus callosum missing, very few fibers bridging across, and therefore I know that it's a Walker-Warburg, and I guide what I need. So this is how we shift over to that. In the next 5 minutes, I will tell you that yes, you do need to use a lot of transducers, and the transducer, which is transvaginal, is certainly the best. The next thing that you need to know is that the checklist that you need to use is always this, and it must be covered. Which means you look at the skull and the spine, the bony part of it, the lateral ventricles, the anterior complex, which is constituted by the cavum septum pellucidum and the lateral ventricles and the corpus callosum, the interhemispheric fissure, the sylvian fissures, the cisterna magna, the cerebellar hemisphere, the vermis of the cerebellum, any cyst-like lesions, and any other lesions that you see. Remember also that you have to go into detail, which means that you must see how long is the cavum septum pellucidum compared to its width, and it should be at least 1.5 times as long, and only then it is normal. And it's a great thing to actually be looking at when you're looking at this. Do remember that it disappears by about 37 weeks. The other thing you should realize is that the vermis of the cerebellum is always far more echogenic, and that is again something that you should realize. And beyond that, you look at the cisterna magna, and it always has reflections of what we used to believe were arachnoid reflections, but we know now that these are remnants of the Blake's pouch, and we always like to use that. Remember that the measurement of the lateral ventricles is also part of the neurosonogram, and then we have this kind of a measurement, which is the cross should have its vertical portion inside the black, and the same on the other side. This is the marker point at the point of the parieto-occipital sulcus, and that is where you do it. For the midline, we use this plane from the front, and therefore it will show you the corpus callosum and the vermis of the cerebellum. And laterally, if you incline your transducer and you're still going through the anterior fontanelle, you will be able to see the frontal horn, the temporal horn, and the occipital horn, and the atrium with the choroid plexus within it. Remember that if you don't do this mid-sagittal plane, you will not be able to differentiate between a normal Blake's pouch, between a Blake's pouch cyst and a Dandy-Walker malformation. And there's a huge difference in the prognosis. So this mid-sagittal plane, in fact, is truly moving on to actually looking at the to be looked at even in your normal routine anomaly scan. Then, of course, we say, all right, the 4 coronal planes from front to back are the interhemispheric fissure, this plane, which is the transcaudate plane, the caudate nuclei are here, the lateral ventricles are here, the corpus callosum is above the cavum septum pellucidum, and here you have the interhemispheric fissure. As you go back and back, you have the transthalamic plane, because this is thalami and thalamus. And as you go further back, you will notice the 2 halves of the cerebellum as well as the occipital horn. Remember that later in pregnancy, after about 24 or 26 weeks, if you look at this level near the sphenoid, you'll also be able to pick up the olfactory sulcus, and that can be very useful for syndrome identification. There are certain subtle things you should always look for, which we often forget. One is that the skull should have an appropriate shape, and if it doesn't have a right shape, you know that the lemon shape is for neural tube defects, that this particular kind of a clover-leaf skull will tell you about thanatophoric dwarfism, and a strawberry skull will tell you about trisomy 18. You also have to remember that you have to trace the entire bone from front to back and look for any defects either anteriorly or posteriorly, and something that you and me rarely do, and that is to look at the density of the skull. If you look at the density of the skull, you have to press it. And if it gets pressed, you know it's not ossified, and that immediately tells you that you're looking at a dysplasia. When it comes to the spine, we do realize that the views that they ask us to do are transverse views and mid-sagittal views. In our world, with the high incidence of neural tube defects, we must also include a coronal view of the spine, because that can show you a lot more. This particular view should always be that, so make sure that you study this as well. Remember that looking at the spine is not just looking at the bones, but making sure that you see the level of termination of the cord, and that should be at the L2, L3 level, and you measure it by looking at the iliac wing, and that comes at the L5 level. So this is the way we look at this, and again for the spine, 3D helps tremendously because it tells you the relationship between the bodies, the lateral processes, as well as the ribs. Remember that you can see the other bones as well, such as the clavicles here, the iliac wings here, and the scapula on either side. So we must understand that yes, this is the way to go about it, but do we need to do it all the time? And the answer is no. This is a problem-solving modality, and in a routine risk pregnancy, when you do your anomaly scan at 20 weeks, if the transventricular plane and the transcerebellar plane are satisfactorily obtained, the head measurements are within the normal limits for gestational age, the width of the atrium is less than 10 millimeters, and the cisterna magna is between 2 and 10 millimeters, the risk of a CNS abnormality is exceedingly low, and further examinations are not indicated. We will do this examination only if it has those specific indications, and those then become extremely important because there's no point just going on and on and on doing tests when it's not going to help. And so therefore these are the indications for a neurosonogram. A suspicion either in the 12-week scan or the 15-week scan or in the 20-week scan. If there is a family history of these, if there is a previous pregnancy with a complication, if the fetus has other abnormalities, particularly congenital heart disease, in monochorionic twins, and this is all of them, in suspected congenital intrauterine infections, exposure to teratogens which affect neurogenesis, such as anti-epileptic medication, such as antidepressant medication, and of course, in case you have a microarray on an amniocentesis, which has shown a variant of unknown significance. So these are the situations where you will do this whole exercise, and now I will demonstrate all of this to you on a patient, and I do hope the patient is a little older than 17 weeks because then I can actually show it a lot better. You noticed how much of a struggle it was when we saw that, and only an expert can manage that kind of an evaluation. I mean, we saw every single part of the anatomy, and you were lucky that we had the right operator because most of us on a routine basis would not be able to see so much. So now let me see what my luck is, and I had requested that we do a 24-weeker with a little polyamnios, but let me see if my dream comes true. Thank you very much, and we go ahead with the second part.